CPAP is a cornerstone of non-invasive support for infants with bronchopulmonary dysplasia, particularly for those with parenchymal or airway-predominant disease. CPAP splints the pharynx and small airways, maintains alveolar recruitment, and reduces the frequency of obstructive events and atelic trauma. Typical starting pressures are 5 to 6 centimeters of water, titrated to achieve optimal chest excursion, oxygenation, and patient comfort. Common challenges include nasal interface leaks, skin injury, and abdominal distension. Strategies to mitigate these issues include rotating interfaces, adjusting mask fit, and providing gastric decompression when necessary. Monitoring of ventilatory parameters, oxygen saturation, and work of breathing guides incremental adjustments in pressure and support. CPAP serves both as primary support for stable infants and as a bridge following extubation, facilitating lung protective management while promoting alveolar growth and reducing the risk of BPD progression. Nasal intermittent positive pressure ventilation augments, CPAP, by delivering synchronized or non-synchronized pressure-supported breaths, improving alveolar ventilation, reducing work of breathing, and decreasing the risk of extubation failure. NIPPV is particularly beneficial in infants with recurrent apnea, airway malacia, or high ventilatory demand. Challenges include mask leaks, asynchrony, and gastric insufflation, which require careful interface selection and monitoring. High-flow nasal cannula provides humidified, heated gas at high flow rates, offering comfort and easier interface tolerance. While HFNC generates a modest distending pressure that may support the upper airway, it provides less reliable alveolar recruitment compared with CPAP or NIPPV. HFNC is typically considered for infants who are stable but intolerant of other interfaces, or as a step down from CPAP/NIPPV. Selection between NIPPV and HFNC depends on the severity of respiratory compromise, gestational age, and tolerance, with continuous monitoring of oxygen saturation, respiratory effort, and work of breathing guiding adjustments. Proper implementation minimizes airway collapse, maintains effective ventilation, and supports alveolar growth, contributing to BPD prevention and reduced progression of chronic lung injury. Invasive mechanical ventilation is reserved for infants with bronchopulmonary dysplasia, who fail non-invasive support or experience significant respiratory compromise. Lung protective principles are paramount. Tidal volumes are typically maintained between 4 and 6 milliliters per kilogram, with adequate positive end expiratory pressure to prevent atelic trauma without causing over-distension. Ventilator synchrony is critical to reduce volutrauma and ensure effective gas exchange, and oxygen is titrated to achieve target saturations while minimizing oxidative stress. Harmful patterns such as high driving pressures, frequent derecruitment, or large fluctuations in oxygen or carbon dioxide can exacerbate alveolar injury and pulmonary hypertension. Permissive hypercapnia may be tolerated within a safe pH range to reduce barotrauma. Continuous assessment of lung mechanics, blood gases, and patient effort guides real-time adjustments, ensuring that invasive ventilation supports gas exchange while protecting fragile lung tissue. These principles aim to stabilize the infant during periods of acute illness while minimizing further injury that contributes to the progression of BPD. Advanced ventilation modes are employed in infants with severe or heterogeneous bronchopulmonary dysplasia who require precise control of ventilation to minimize further lung injury. High-frequency oscillatory ventilation is used when conventional ventilation fails to maintain alveolar recruitment, particularly in lungs with patchy atelectasis or uneven compliance. HFOV delivers very small tidal volumes at rapid frequencies, allowing gas exchange at lower peak pressures and reducing volutrauma. High-frequency jet ventilation is indicated in cases with air leak tendencies or when ultra-low tidal volumes are needed to limit barotrauma. Both HFOV and HFJV require careful monitoring of oxygenation, carbon dioxide elimination, and hemodynamic stability. Extubation readiness is assessed based on stable blood gases, low ventilator settings, adequate work of breathing, and the presence of adjunctive therapies such as caffeine. Advanced modes serve both as rescue strategies and as lung protective approaches to facilitate recovery, minimize chronic injury, and optimize long-term pulmonary outcomes in infants with severe BPD. Fluid management and judicious use of diuretics are key components in optimizing respiratory function and growth in infants with bronchopulmonary dysplasia. Interstitial pulmonary edema increases work of breathing and may exacerbate oxygen requirement and pulmonary hypertension. Short courses of loop diuretics, such as furosemide, can provide rapid symptomatic relief, while chronic therapy may involve thiazides, often combined with spironolactone to maintain electrolyte balance. Monitoring is critical to prevent adverse effects, including hypokalemia, metabolic alkalosis, nephrocalcinosis, and impacts on bone health due to altered calcium and phosphate balance. Sodium, chloride, and potassium levels should be assessed frequently, and diuretic dosing adjusted according to fluid status, weight trends, and clinical response. The strategy involves weaning loop diuretics first while reassessing work of breathing and growth, with thiazide-only regimens serving as a bridge for long-term management. Effective fluid and diuretic management reduces pulmonary congestion, facilitates ventilation, and supports growth, forming an essential component of comprehensive BPD care. Bronchodilators and inhaled corticosteroids are used selectively in bronchopulmonary dysplasia to address reversible airway obstruction and inflammation. Bronchodilator trials are indicated when objective evidence demonstrates bronchospasm or expiratory flow limitation, such as wheezing, dynamic airway collapse, or poor ventilatory response, and should be discontinued if no measurable benefit is observed. Overuse can exacerbate airway malacia and contribute to tachycardia or agitation. Inhaled corticosteroids are considered for infants with frequent exacerbations or persistent airway inflammation. Their use is typically time-limited and tailored to specific phenotypes, balancing anti-inflammatory benefit with potential systemic effects. Delivery techniques, including spacers with masks and caregiver return demonstration, ensure effective deposition and adherence. Strict adherence to dosing schedules, device hygiene, and monitoring of response allows targeted therapy that optimizes airway function without exposing infants to unnecessary systemic steroid effects, integrating pharmacologic intervention with comprehensive respiratory management in BPD. Systemic corticosteroids are reserved for infants with bronchopulmonary dysplasia who remain ventilator-dependent despite optimized non-invasive support and lung protective strategies. Candidates are typically those with persistent oxygen requirement, elevated ventilatory settings, and evidence of lung inflammation or compliance failure. Dexamethasone, often used in protocols such as DART, is administered to facilitate extubation within a defined window, while low-dose hydrocortisone may be used in select centers. Multidisciplinary review, weighing potential benefits against risks, particularly neurodevelopmental concerns, is essential. Courses are kept as short as possible, with tapering strategies to minimize adrenal suppression and systemic side effects. Objective criteria, such as gas exchange stability, ventilator settings, and extubation readiness, guide therapy continuation or cessation. Close monitoring ensures that steroids provide meaningful improvement in respiratory status while minimizing adverse outcomes, supporting the transition from invasive ventilation to non-invasive or spontaneous breathing in high-risk preterm infants. Optimal nutrition is foundational in the management and prevention of bronchopulmonary dysplasia, supporting alveolar and vascular growth, tissue repair, and overall development. Caloric intake is typically targeted at 150 to 180 kilocalories per kilogram per day, with adequate protein to promote lung growth and weight gain. Micronutrients, including sodium, chloride, calcium, and phosphate, are closely monitored, particularly when diuretics are in use to prevent metabolic disturbances and support bone health. Human milk fortification is individualized to meet caloric and protein requirements, with regular assessment of growth parameters, weight, length, and head circumference, at least weekly. For infants with oral fatigue or feeding intolerance, tube feeding may be required to ensure adequate nutrient delivery. Consistent nutritional support interacts synergistically with respiratory management, reducing ventilator dependence, minimizing oxygen requirements, and promoting pulmonary vascular and alveolar development. Incorporating structured nutritional strategies into BPD care is essential for mitigating chronic lung disease severity and optimizing long-term outcomes in extremely preterm infants. Feeding in infants with bronchopulmonary dysplasia requires careful coordination to prevent aspiration and minimize apnea or desaturation events. Risk indicators include coughing or choking during feeds, oxygen desaturation, bradycardia, wet vocal quality, and recurrent atelectasis, which suggest airway compromise or impaired swallow coordination. Management involves pacing feeds, positioning to optimize airway patency, and using instrumental swallow evaluations when recurrent concerns arise. Thickening agents or modified feeding strategies may be applied on a case-by-case basis, with acid-suppressive medications reserved for confirmed gastroesophageal reflux rather than empiric therapy. Effective feeding strategies integrate respiratory and gastrointestinal considerations, promoting safe oral intake, supporting growth, and reducing the risk of pulmonary exacerbations, thereby complementing the broader multidisciplinary care plan for infants with BPD. Infection and respiratory exacerbations significantly impact the course and severity of bronchopulmonary dysplasia. Viral exposures, including RSV and influenza, can precipitate acute decompensation, highlighting the importance of strict hand hygiene, visitor policies, and prophylaxis where appropriate. Bacterial infections should be treated based on culture results, with narrow-spectrum therapy preferred to avoid disruption of the airway microbiome. Prolonged empiric antibiotics are discouraged. Airway care is essential to prevent exacerbations. Gentle suctioning minimizes trauma and avoids triggering apnea or malacia-related airway collapse. Prompt recognition and treatment of infectious or inflammatory triggers reduce the risk of additional lung injury, improve gas exchange, and help maintain growth trajectories. Structured infection prevention and management, integrated with ongoing respiratory support, are crucial to maintaining stability and reducing the cumulative risk of chronic lung injury in infants with BPD. Airway malacia is a common structural complication in infants with bronchopulmonary dysplasia, resulting from weakened or completely developed tracheal and bronchial cartilage. Clinical cues include positional desaturations, expiratory wheezing, flattened ventilator flow curves, and recurrent atelectasis, often exacerbated during feeding or sleep. Diagnosis is confirmed with flexible bronchoscopy or dynamic imaging, allowing visualization of airway collapse and assessment of severity. Management is tailored to the degree of obstruction. Optimization of non-invasive support with CPAP or NIPPV maintains airway patency, while surgical interventions such as aortopexy may be indicated in severe cases. Recognizing structural airway compromise is critical to adjusting ventilatory strategies, preventing repetitive hypoxemia, and supporting alveolar growth, thereby reducing additional injury and improving both immediate respiratory stability and long-term pulmonary outcomes in BPD infants. Pulmonary hypertension is a frequent and high-risk complication in moderate to severe bronchopulmonary dysplasia. Screening is typically recommended around 36 weeks post-menstrual age for infants with significant oxygen or ventilatory support needs, or earlier if hypoxemia, poor growth, or disproportionate ventilatory requirements are observed. Echocardiography is the primary tool for non-invasive assessment, focusing on tricuspid regurgitation jet velocity, right ventricular systolic pressure, septal flattening, pulmonary artery acceleration time, shunt direction through a patent ductus arteriosus or foramen oval, and right ventricular function. Additional adjuncts include B-type natriuretic peptide trends and analysis of nocturnal or feeding-related desaturations. Early identification allows prompt initiation of targeted interventions, including oxygen optimization, nutritional support, and, if indicated, pharmacologic therapy. Regular monitoring supports early detection of progression, guides therapy titration, and informs both prognosis and multidisciplinary care planning for long-term outcomes. Management of pulmonary hypertension in infants with bronchopulmonary dysplasia focuses on optimizing lung function, reducing pulmonary vascular resistance, and supporting cardiac output. Primary strategies include ensuring adequate oxygenation, correcting hypercarbia, preventing aspiration, and providing appropriate nutritional support to facilitate growth and tissue repair. Pharmacologic interventions are applied in selected cases. Sildenafil is commonly used as first-line therapy to lower pulmonary vascular resistance and improve right ventricular function, with other vasodilators considered on a case-by-case basis in consultation with pediatric cardiology or pulmonary hypertension specialists. In severe or refractory cases, cardiac catheterization may guide therapy prior to initiation of long-term vasodilators. Monitoring is critical and includes serial echocardiography, evaluation of biomarkers such as BNP, assessment of functional status and growth, and careful titration of supplemental oxygen and medications. The goal is to maintain pulmonary perfusion while minimizing further lung injury, supporting both immediate stability and long-term cardiopulmonary outcomes in BPD infants with pulmonary hypertension. Infants with bronchopulmonary dysplasia undergoing anesthesia or procedures require careful preoperative assessment and planning. Key considerations include evaluating pulmonary hypertension status, oxygen requirements, recent respiratory stability, and fluid and electrolyte balance, particularly if diuretics have been used. Understanding ventilatory needs and lung mechanics is essential to minimize perioperative decompensation. Intraoperatively, goals include avoiding hypoxemia and acidosis, maintaining controlled ventilation with lung protective settings, and carefully managing airway pressures and fluid administration. Postoperatively, close monitoring of oxygenation, ventilation, and hemodynamics is critical to detect early deterioration, guide escalation of support, and prevent complications such as pulmonary hypertensive crises or ventilator-associated injury. Structured perioperative planning, incorporating multidisciplinary input from neonatology, anesthesia, and surgery, ensures safe procedural care and minimizes adverse outcomes in high-risk BPD infants. Emerging and investigational therapies in bronchopulmonary dysplasia target inflammation, vascular development, and alveolar growth to mitigate ongoing lung injury and improve long-term outcomes. Anti-inflammatory strategies include budesonide delivered via surfactant, which may reduce local airway inflammation while minimizing systemic steroid exposure, and selective systemic corticosteroid regimens under clinical study for high-risk infants. Vascular-targeted therapies such as endothelin antagonists or prostacyclin analogs are being investigated in infants with BPD-associated pulmonary hypertension at specialty centers. Cell-based approaches, including mesenchymal stromal cell-derived therapies, aim to promote lung repair, modulate inflammation, and support alveolar and vascular development. Dosing, route, and timing remain under investigation. Biomarker-guided risk enrichment is an emerging strategy in clinical trials, integrating inflammatory, oxidative, and vascular markers to identify infants most likely to benefit from targeted interventions. These investigational approaches are not yet standard care, but offer insight into mechanistic pathways and potential future therapies, emphasizing the need for careful research, ethical oversight, and multidisciplinary collaboration when enrolling BPD infants in clinical trials. Management of oxygen therapy and discharge planning in bronchopulmonary dysplasia focuses on balancing adequate oxygenation with minimizing oxidative injury and ensuring safe transition to home. Inpatient strategies include continuous monitoring of oxygen saturation trends, identifying clusters of desaturation, and synchronizing feeds to prevent hypoxemic episodes. Pre-discharge evaluations involve car seat and feeding trials conducted on the intended home oxygen plan, ensuring the infant maintains adequate saturations and ventilation under real-world conditions. A written home oxygen plan specifies target saturations, flow rates, and equipment operation, along with backup supplies and emergency procedures. Caregivers are trained in the use of oxygen delivery devices, including interface troubleshooting and safe handling to minimize risks. Coordination of follow-up appointments, medication instructions, and feeding strategies ensures continuity of care. Structured monitoring, appropriate education, and clear guidelines support safe discharge, promote growth and neurodevelopment, and reduce readmissions by anticipating and preventing complications related to persistent oxygen dependency in infants with BPD. Discharge planning for infants with bronchopulmonary dysplasia focuses on ensuring safety, continuity of care, and optimization of growth and respiratory function at home. A comprehensive oxygen plan specifies target saturations, flow rates, device operation, and backup supply, as well as strategies for travel and emergencies. Caregivers receive training on oxygen delivery, interface troubleshooting and safety precautions to maintain effective and safe oxygen therapy. Medication and feeding instructions are individualized. Diuretics, inhaled medications, and fortified feeds are carefully managed, with instructions for monitoring response, timing, and technique. Strategies to prevent aspiration, such as pacing and positioning, are emphasized, and caregivers are educated on early warning signs that require prompt intervention. Written plans, including emergency contacts and stepwise escalation protocols, support consistent care. This structured approach ensures a safe transition from the NICU to home, promotes growth and neurodevelopment, and minimizes the risk of readmission by providing clear guidance and caregiver confidence in managing infants with BPD. Structured outpatient follow-up is critical for infants with bronchopulmonary dysplasia to monitor growth, respiratory stability, and long-term development. In the first 1 to 2 weeks after discharge, weight trends, oxygen requirements, and feeding tolerance are closely assessed to ensure safe transition from inpatient care. Follow-up at 1 to 3 months focuses on growth trajectory, weaning or adjustment of medications, and echocardiographic surveillance if pulmonary hypertension is present. Beyond this period, care shifts to long-term preventive and developmental monitoring, including immunizations, infection prophylaxis, pulmonary function assessment, and transition planning. Multidisciplinary involvement, pulmonology, nutrition, developmental therapy, and cardiology when indicated, ensures early identification of complications, guides intervention, and supports ongoing optimization of respiratory function, growth, and neurodevelopmental outcomes in infants with BPD. Pulmonary function in bronchopulmonary dysplasia evolves from infancy through adolescence, reflecting both initial lung injury and compensatory growth. In infancy and toddlerhood, residual small airway obstruction, air trapping, and reduced functional residual capacity may be detected using raised volume rapid thoracoabdominal compression techniques or bedside flow measurements. These impairments often correlate with increased work of breathing and intermittent desaturation. During school age and adolescence, survivors frequently exhibit persistent reductions in forced expiratory volume relative to forced vital capacity, FEV1/FVC, diminished diffusing capacity for carbon monoxide, and limited bronchodilator responsiveness, despite lung growth. Exercise intolerance, cold air reactivity, and asthma-like symptoms are common, though pathophysiology differs from classical asthma. Cohort studies suggest partial improvement with age, but residual risk remains, emphasizing the need for ongoing surveillance, individualized respiratory management, and guidance on environmental exposures to optimize long-term lung health and functional capacity. Long-term outcomes in bronchopulmonary dysplasia are influenced by initial severity, duration of ventilatory support, oxygen exposure, and comorbidities such as pulmonary hypertension or airway malacia. Pulmonary consequences include chronic airflow limitation, hyperinflation, reduced exercise tolerance, and increased susceptibility to respiratory infections throughout childhood and adolescence. Extrapulmonary outcomes are also significant. Growth impairment may persist despite optimal nutrition, and neurodevelopmental delays, including cognitive, motor, and behavioral deficits, are common, particularly in extremely preterm infants. Cardiac complications, including persistent pulmonary hypertension and right ventricular strain, may require ongoing cardiology follow-up. Quality of life and school performance can be impacted by the combined effects of chronic lung disease, neurodevelopmental sequelae, and recurrent hospitalizations. Long-term multidisciplinary follow-up is essential to monitor pulmonary function, guide interventions, optimize growth and development, and support the family in navigating ongoing healthcare needs. Family education and caregiver training are integral to safe, effective long-term management of bronchopulmonary dysplasia. Caregivers must be proficient in the operation of home oxygen systems, including flow adjustment, alarm recognition, and troubleshooting. They should also be trained in recognizing early signs of respiratory distress, apnea, or feeding intolerance, enabling prompt intervention and reducing the risk of emergency hospitalizations. Feeding techniques, pacing, and aspiration precautions are emphasized for infants with airway instability or dysphagia. Families are instructed on proper medication administration, including inhaled therapies, diuretics, and nutritional supplements, with monitoring for side effects and efficacy. Structured education programs, return demonstrations, and written care plans ensure caregivers are confident and capable, supporting adherence, early detection of complications, and overall infant growth and developmental outcomes. Empowering families in these skills is critical to promoting stability and quality of life for infants with chronic lung disease. Unit-level quality and safety practices play a crucial role in reducing the incidence and severity of bronchopulmonary dysplasia. Standardized protocols for oxygen titration, non-invasive ventilation, and ventilator weaning minimize exposure to high pressures and hyperoxia, reducing volutrauma and oxidative injury. Structured bundles include early caffeine therapy, meticulous fluid management, and judicious use of surfactant and systemic steroids. Routine data collection and audit cycles enable continuous assessment of outcomes, identifying deviations from best practices and opportunities for improvement. Multidisciplinary rounds, including neonatology, nursing, respiratory therapy, nutrition, and pharmacy, ensure coordinated, evidence-based care. Staff education on interface selection, alarm management, and gentle handling further minimizes iatrogenic lung injury. By integrating standardized care bundles, continuous monitoring, and staff training, NICUs can reduce variability in practice, optimize early lung protection, and improve both short and long-term outcomes for preterm infants at risk for or diagnosed with BPD. Systematic collection and analysis of clinical data are essential for understanding trends, evaluating interventions, and improving outcomes in bronchopulmonary dysplasia. Key metrics include incidence and severity of BPD by gestational age, duration of mechanical ventilation, oxygen exposure, growth parameters, rates of rehospitalization, and long-term pulmonary and neurodevelopmental outcomes. Integration of electronic medical records, unit dashboards, and quality improvement databases allows real-time monitoring of adherence to care bundles, oxygen targeting, and ventilation strategies. Benchmarking against local, national, or international standards helps identify performance gaps and guides targeted interventions. Regular review of data supports evidence-based adjustments to practice, facilitates staff education, and informs research initiatives. Tracking outcomes longitudinally also aids in family counseling, resource allocation, and policy development, ensuring that care strategies are continuously optimized to reduce BPD incidence and severity and enhance long-term health for preterm infants. Bronchopulmonary dysplasia represents a multifactorial chronic lung disease in preterm infants, resulting from the interplay of developmental immaturity, prenatal exposures, and postnatal insults such as mechanical ventilation, oxygen toxicity, and inflammation. Pathophysiologically, BPD is characterized by alveolar simplification, impaired secondary septation, dysregulated vascular development, and airway malacia, leading to reduced compliance, ventilation, perfusion mismatch, and increased susceptibility to pulmonary hypertension. Risk stratification incorporates prenatal contributors, including intrauterine growth restriction, chorioamnionitis, and antenatal corticosteroid exposure, along with early postnatal modifiers such as oxygen exposure, ventilatory strategies, infection, and nutrition. Management requires a stepwise, individualized approach, integrating gentle ventilation, caffeine therapy, targeted pharmacologic interventions, nutritional optimization, and non-invasive support. Multidisciplinary involvement across inpatient and outpatient care, with structured follow-up, oxygen management, and family education, is essential for mitigating long-term pulmonary, cardiovascular, and neurodevelopmental morbidity. Unit-level quality initiatives, data tracking, and adherence to evidence-based bundles further enhance outcomes. Collectively, these strategies emphasize proactive, integrative care to prevent progression, support lung growth, and improve survival and long-term quality of life in infants with BPD.